We're going to, we spent a lot of time this morning talking about rural communities and lessons learned from HIOs as they started up, and then we rolled into patient consent or patient permission as we're referring to it, and now we're going to spend the rest of the day bringing our focus in a little bit more. And our first session, as you can see from on your agenda this afternoon, is going to be about the role of registries and in transforming healthcare. Someone asked me this morning if we were going to talk about the accountable care environment and the role of HIEs in that. And I really think, as those of you who were able to join us for the last summit know, we focused on that quite a bit at the last summit. This summit, though, we're really just, we're focusing in more on how this is just an underpinning of everything we need to do to change the healthcare environment. So registries are critical tools, as you may know, for measuring and improving the quality of care and understanding disease processes, as well as disparities, treatment trends, and among other aspects of healthcare that need to be impacted. And this session specifically is going to explore significant registry developments in California and how those registries and those developments are changing the way we provide healthcare, including work that's been done under our grant with the California Department of Public Health, specifically with the Project Inspire, the HIE Gateway. Our presenters today are Dr. Esty Garrity, sitting here immediately to my right, Dr. Mike Hogarth, a familiar face to those of you who've attended summits in years past, and Van Vu, and we look forward to hearing from all of you and the lessons you have to share with us. So thank you.
Thank you, Pam. Well, it is such a pleasure to be here and to particularly be here with my esteemed colleagues, Van Vu and Mike Hogarth, to talk to you about the role of registries in transforming healthcare. Make sure my slides are up. There we go. So I'm going to start this conversation by talking about the value of registries to a number of different kinds of stakeholders. And then Van is going to talk about the California Department of Public Health's Health Information Exchange Gateway, which is our one-stop shop for data submission to these registries. And then Mike is going to ask you to think beyond the present and look toward next-generation registries and Project Inspire. Now, many of you may be familiar with CARE 2.0, which is California's immunization registry. But if you're not already familiar, basically, this is a project that consolidates the 7 regional California immunization registries, but also enables interoperable connectivity with 3 independent registries. You heard about one of those earlier today. So basically, it makes a single statewide immunization registry. Now, our registry uses modern software that enables HL7 messaging and is compliant with our state IT standards. So why should we have a statewide immunization registry? Well, I'm probably preaching to the choir here, but there are a number of benefits to parents, for example, who would like to have all of their child's information consolidated into one record. That way, when families move or change providers, all of their records are in one place. And they're available for when children do things like go to daycare, go to school, or to camp. So it's going to be a lot easier, too, for parents to and providers to watch a child's immunization history and make sure that they stay up to date. And if they're not up to date, then they can send reminders, and that will be easy. I have to say that something like this would have been useful when I was younger, a lot younger, and I did have all of my regular childhood immunizations. But when I went to university, my mother and I could not find that little card that had all of my immunizations on it, so I got re-immunized for everything. Well, you would think we would have learned something from that, but no. When I went to medical school, my mother, myself, and my provider could not find my immunization records, so I got the shots 3 times. I am fully protected. Now, providers, plans, and purchasers are going to benefit from a statewide immunization registry by having reliable immunization history for that child who may be new or continuing on in a particular practice. It's going to make it really easy for providers to submit their required reports, and it's going to probably improve medical decision making. It's going to increase efficiency and reduce paperwork because you're not going to have to do those records requests just to get the immunization history. So I think that's going to make providers especially very happy. And all of this really speaks to the idea of the patient-centered medical home and improved coordination of care. And even as you think about it, it's going to help us to manage our vaccine inventories. Now, there's no doubt that communities are going to benefit from statewide immunization registries because we're going to be able to identify those high-risk and under-immunized populations who can then be targeted for additional resources to start to prevent vaccine-preventable diseases. And of course, public health officials are going to be very happy because they're going to be focused on targeting those populations that are in need, as well as offering guidelines for immunization practices, evaluating programs, and even looking at adverse events. But if you're still not convinced, I would ask you to consider this. For every U.S. birth cohort that is immunized, 33,000 lives are saved, 14 million cases of disease are prevented, and over 43 billion, yes, that was with a B, dollars are saved when you combine the direct and the indirect costs. So imagine, for California, when we take advantage of a statewide immunization registry, then we'll get to reap our share of those benefits. So I wanted to show you these maps just to give you a sense of why this is so critical in California. So these maps show the number of individuals who are in an immunization information system. And this is for 2012, and darker colors indicate more in an immunization system, an electronic system, whereas lighter colors are fewer. So keeping an eye on California, this is for kids under 6, this is adolescents, and this is adults. So we look forward to a year from now and beyond when we can show California as a much more darkly colored state. So now I'm going to switch gears a little bit and talk about what's going on in the California Cancer Registry as another example. So as you may have guessed, there is a strong emphasis in the Cancer Registry to eliminate the outdated paper-based processes. And to that end, a web-based system has been developed that will allow providers to submit their cancer cases electronically. So this is a great thing, but also internal systems are being automated, like quality control processes, patient identifying algorithms, and tumor consolidation. And if you're not familiar with that term, what it means is that all of the information about a single primary tumor for a person is in one place. So the diagnostic information, staging, treatment, and follow-up information. So there's another issue related to the Cancer Registry that is kind of unique to cancer, at least if you compare it to immunization registries, and that is a lot of the rich information that could be reported and is reported in cancer cases is in unstructured text-based resources. So this is an ongoing problem where we're looking for solutions to handle it. And also, I'm sure many of you know that Meaningful Use Stage 2 is a major driver of getting these electronic registries going. So how does this transform healthcare? Well, the electronic submission of cancer cases to a registry has the potential to really speed up the surveillance process, the reporting process, which is now at 24 months. So imagine if this was much faster, what kinds of opportunities would exist in research and in providing clinical trials, for example. And when you think about the burden of putting together these cancer cases, which I've learned is extremely time-consuming and very expensive, that will all be significantly relieved when these data are submitted electronically. And as we go toward the more structured data, or being able to pull out that unstructured data, think of, for example, treatment data, which is not currently in the cancer registry. If we could pull out that treatment data, what kind of a boon would that be to research when you could look at the outcomes related to particular treatment regimens, or you could look at places where best practices are being done, and then you could even sort of evaluate for disparities in cancer treatment. So all very important, and I do think transformative for healthcare. But I do want to ask you, or let you know, why do we care about this in cancer in particular? Because North America has the second highest cancer incidence rate in the world. And so now to give you a peek at the California Department of Public Health technology solution that's going to move our registries forward, I'd like to introduce Van.
Hi everyone, I am very honored to be here to represent the Department of Public Health. My name is Van Vu. Just going to learn how to use this clicker. I will be speaking about our HIE Gateway and the innovations that are behind it. As you know, there are two very valuable registries that you just heard from Dr. Garrity, but there are 240 programs and registries within public health. And that's not to mention the local health departments there are 61 of them throughout the state. So we are very much wanting your data. We need your data, we want your data, and we use that data for, of course, public and population health, for research, scientific research, and we also are implementing public health surveillance and preparing for emerging threats. We're using it for many different things, such as healthcare quality, and lastly, to drive health policy. So we need your data, and we want your data. If anything, we know that needing and wanting your data is far from actually getting your data. So we need to know and put ourselves in your shoes. We know that there's a lot of confusion out there in terms of where to send the data, who to send it to, what data to send, how to send it. And we want to lessen the confusion. We want to make it efficient for you to send data to us. We want to make it easy, or at least less complicated to you in terms of how do you connect to us, okay? So as you can see from this diagram, there are so many arrows flying back and forth. Who do you send to? Do you send to the State Department? Do you send to the local health jurisdictions? There's a lot of information out there. So we wanted to find a way to assist you in this. And so that is why we developed the Gateway. But I want to at first say a great thank you to Pam Lane, Cal Ojai, Christine. Thank you for helping us set up the immunization portal, because that stimulated us to think further. Now, what can we do with our other programs that also needs to receive data for meaningful use in terms of electronic lab reporting, or cancer case reporting, or specialized registries? Or what about our other 200 programs out there? And so we thought that there needs to be a way. What can we do to scale it out, the technology, to build an infrastructure that can actually exchange data with external stakeholders as well as within? So we developed this HIE Gateway, and we knew that we needed to reuse the resources that we had. We needed to collaborate with the local health jurisdictions and to our sisters departments. So we decided to do this, and we only had a short time because we wanted to prepare for Meaningful Use Stage 2. So, with that said, our HIE Gateway has two parts. It has the registration system, and it also has an onboarding piece to it. And the registration system is supposed to help with meaningful use in terms of allowing you to get confirmations when you've registered, so that you have registered within 60 days and that you can get your incentive money. And then it also has affirmations so that you know, or acknowledgments so that you know that you are testing. We can automatically queue you or queue your submission because you are sending data to us, and you could be sending it to multiple program areas. And that's why we wanted a one-stop shop, because we know you would be searching for public health, and you would find many different programs and many websites that you'd have to read up on and to just connect to us. So our message gateway is also automated. And so when you start to submit and you have ongoing submission, we will let you know that. And that way you can continue to send data to us. So here it is. This is our HIE gateway, and this is where you can find it. Now, we understand that there's multiple websites that you had to go to, so we consolidated everything. On this web page, you should be able to find information on CalReady, on the CARE, our California Immunization Program, on our cancer case, our California Cancer Registry, our childhood-led poison prevention program, and then there will be more. And then we wanted to show you how easy it is to register with us. So we have quick guides, and we'll put on their FAQs. And so we will guide you through the process so that you can send data to us. We also have the registration and login link. If you look towards the left, that's where you would want to click so that you can start your registration process. Other questions with this? We actually wanted to keep in mind that we are receiving data from Meaningful News, but we want it to be innovative. We want to be able to send out data one day, and we also want to have a data warehouse. So we're keeping a lot of innovations in mind so that we can actually scale out to many program areas. So I really want to thank you. Thank you to eRecords and to Adventist Hospital Group who helped pilot this HIE Gateway. And we also want to thank you, Cal Ojai, the Department of Healthcare Services, and our regional extension centers. We wanted to promote our HIE Gateway. Right now, we actually have 1,800 folks registered to send immunization information and electronic lab data, as well as 500 who are connecting and testing. And then we have 400 in production. So you're sending data to us, and we're very, very thrilled and very, very thankful. And then lastly, there's 100 that are in testing. So we know the numbers, and we know who you are, and we're very glad to have you on board. So thank you very much for your time.
Thank you, everybody. Thanks for having me again. I think this is my 4th time or something. I'm glad you're not tired of me yet. I'm going to speak about next generation registries, so I'm just asking you to sort of stretch your mind. This isn't production grade, you know, like that. So this is innovation, and when we innovate, we take risk. So just keep that in mind. So this is about, you know, what can we do with registries beyond what we're doing today? So that's kind of what this talks about. Yep. So the concept here is, can a longitudinal record in a registry really help improve care? So care, for example, in high-impact conditions like cancer is very fragmented. A cancer patient will be diagnosed within 4 to 6 weeks. They've seen 6, 7 providers. If you're outside of Kaiser, these 6, 7 providers often don't exchange data electronically, and sometimes don't even talk to each other. The patient's doing the talking between them, which is often the case. A complete view of the patient's record really requires assembling data slices from all the providers. So, if a registry, it's a big if, had data that was high quality, timely, available to providers, can it facilitate care? Because care coordination would be facilitated that way. So that's kind of the concept. So next generation registries is the name of this concept. And today's registries, really, we have traditional registries often used, as has been said before, for surveillance, public health, pharmacovigilance, understanding who has devices or implantables. Traditional registry records really are not made available for clinical care today. In fact, there's sometimes legislative obstacles to that, not because of privacy necessarily, because of funding. Imagine a cancer registry now having to be part of the clinical care process. That might invoke a lot more costs for the state. Traditional registries often use data abstraction, as was mentioned before, for data capture, which is expensive, time-consuming, and sometimes leads to incomplete records. So can we add value with something like this? where the same patient data, is available that we use for care, and we would submit to the registries, is the same data often that's used for good clinical care. So they're really the same kind of data generated by the same process. Can we put that data in a longitudinal record somewhere that's not the cancer registry at the state, but a place where providers can have access to it, and facilitate better data capture at the point of care to improve the data quality? So that's what's behind the project that I'm going to talk to you about. So this should be familiar to many of you. This is today's clinical data landscape, otherwise known as the landfill. And yes, woo. And even with EHRs, it doesn't get much better. It just, bad gets faster, not better. This is the typical process for registry data acquisition. So any of you who work in a hospital will be familiar with this. And if you have an EHR, you just exchange the paper for screens, but you're still foraging for information. It really isn't teed up for you. So here we are. We've invested billions of dollars as a country, and we're getting EHR adoption. It's actually happening, which is amazing. So we're going to have a future where most providers will be using electronic healthcare records to render care and treatment. They'll be using these routinely. We hope to have routine information exchange. And then EHR to public health will be also routine, as was mentioned before. So using that kind of as a context to think about the future, what should we be thinking about? And that was kind of the inspiration behind the project. And then one last thing here, EHRs alone won't fix everything. So everybody says, oh, we'll just adopt EHRs and everything will be better. It might be better, but it might surprise you to know that generating a unified whole record really requires you to access multiple different systems. I'm preaching to the choir. And somebody with cancer, for example, or anybody with a chronic condition sees at least 2 to 4 different physicians a year, many of whom don't exchange data today. So just having EHRs is not going to do the trick. And then there's more bad news. The irony of EHRs and physician productivity and what I call information finding or foraging. Data is starting to come out, and some of you who are physicians in the room, if you use an EHR, you'll understand this right away. But this idea, of using EHRs is becoming a process of creating large, hard to construct and read notes. We call it note bloat. A lot of times it's automatically inserted lab data and the like. And so those key pieces of information we need to take care of patients are little gold nuggets now that are really hard to find. They were hard to find when I couldn't read somebody's note. Now I can read the stuff, but now I have mountains to read. So I spent a lot of time constructing these myself because I'm supposed to for billing purposes and regulatory purposes. And then I also spent a lot of time sifting through these notes. And there's a couple of studies now done by Clem McDonald, which were reported by him earlier in a conference, which are really fascinating. He looked at how long it takes physicians to practice really and document with an EHR, and he's finding now about 40 to 45 minutes lost productivity per physician per clinic day. Now translate that to 500,000 physicians around the country. So EHRs are good for productivity elsewhere. They'll save us $2 trillion. That's another study. But physician productivity is not where the saving is today. So we have to change things a little bit. And the data quality is terrible. We cut and paste. So another study showed 90% of physicians are doing cut and paste. And when they said, are you serious? That's not really good. Yeah, I know. Well, you're going to continue? 80% said they would. How does that make sense? All right, so that's the backdrop. The project is INSPIRE. It stands for Interoperability to Support Practice Improvement, Disease Registries, and Care Coordination. It's a mouthful. And it really is about acquisition and exchange. So improving acquisition of data and exchange for patients with high-impact conditions like cancer. So there are really 2 initiatives in INSPIRE, and these are underway, going on right now. One is around data capture. Develop and demonstrate point-of-care data capture in a different way, not the note bloat maneuver, not the cut and paste maneuver, but decreasing the time it takes to document and making it a high-value documentation. And that's something we call the health information home. And think of it as kind of the registry outside the public health department that you can interact with as a clinician and see a longitudinal record. The CIOs in the room, if I say this, will have a cow. But the way I explain it to some of my colleagues who are physicians is I call it the secure medical drop box, and they instantly say, where can I get an account? The CIOs in the room go, oh my gosh, no. And then they follow it with, why would you need that? I have all the data you need, which is not true. You have a slice. We need all the slices together to make a longitudinal record, so we need all the slices together in one place. So that's what's behind that. So we decided to do a demonstration project. We used an existing network called the Athena Breast Care Network. 200 physicians of all types, pathologists, radiologists, surgeons, all working together. They meet 4 times a year, really supported by the UC system as well as the Safeway Foundation, who donated $25 million for that project. The idea is to track 150,000 women for 10 years, kind of a Framingham for breast health. And we're using that as a backdrop because in that mix we have 5 institutions, 10 hospitals, everybody using EHRs. It's an electronic, essentially, practice environment. And 2 out of those 5 institutions are HIMSS level stage 7. And 1 actually won the Davies Award this year. For those of you who know what that is, I won't say who did that, but it was an institution somewhere around Sacramento. And then so the first thing we did was, what would you do if you wanted to fundamentally change a process? What's the first thing you do? This is a quiz. I'm an educator, you know. Prize goes to the first right answer. Workflow. Process map. What is today's workflow? So that's what we did. 800 interviews, lots of hours. Workflow is amazingly complicated. And we started looking at what are the pain points. And look at the pain points. Does this surprise you? Clem McDonald found the same thing. The pain point is difficult to find information across all the providers that are also taking a long time to make documentation that everybody else finds difficult to read. So that's kind of strange, right? And we have electronic systems. It just makes it faster, but not better. Anyway, so one of the first things we're tackling is it all starts with good data capture. So how do we accomplish that? So our approach is ask providers to enter structured data only for key data elements. Providers fill out these, what we call checklists. They respond well to checklists, not templates. But essentially, they're electronic templates in the EHR at the point of care. And data submitted to a central registry, I call it, or the Health Information Home, for longitudinal records using new standards. CCD is great. Don't get me wrong. You cannot package a treatment summary in cancer in a CCD. You have a medication list. Which ones were the medications that were part of a treatment plan? You cannot assemble that. That's very difficult to reassemble. And we're not the only ones that thought of that. We actually thought of it independently, and ASCO and HL7 were thinking that way before us. And some of you may know about the ASCO HL7 Treatment Summary CDA, which we now are borrowing for this project. So the goal here is enter once, use many, okay? And then implementing that, this is for the techies in the group, there actually is an XML specification that has been constructed or built or designed by the College of American Pathologists for synoptic reporting. It is not pathology specific. XML doesn't say you have to be pathologist to use it. So you can use it for any kind of template. Think of it as an XML specification to define a form for data entry. And 3 major EHR providers already do this in their lab modules. So for them to do it elsewhere in their systems would not be hard. So one of our big concepts here is to make sure it's translatable. All right, so here's just a screen capture of actually an XML from the CAP and synoptic reporting, creating actually what they call an electronic checklist or ECC form template. And we're working with them and with the ONC SNI framework folks to really promote this idea as a way of providing XML-driven templating. So you don't have to have programmers go there and construct the stuff. And the XML templates can be distributed by professional societies, the state, whatever, and they're loaded up. So it relieves actually the EHR vendor from the content issue often that they have difficulty with these templates. And then exchanging the data, we're using CDA and we're just extending the CCD. We've coined the term CACCD just because we're doing it in cancer, and it seems to have stuck because the incoming president of ASCO is now calling it CACCD instead of the ASCO HL7 CDA. But it is the ASCO HL7 treatment summary, and we're implementing that for this project. So last but not least, the health information home. So sort of notion of parking this data in the community. You know, we've always talked about HIEs as a place to exchange. It's fascinating. Most HIEs that do exchange also do something like this. They'll park lab data. They'll park other data. They'll park reports. You can go and log in on the website. You essentially have an emerging longitudinal record on patients. So what we're thinking is you should do that in a formal way around diseases that are high impact, like cancer, AIDS, other diseases like that, cardiovascular disease, et cetera, that are high impact. And then with the appropriate standards and packaging of data, you should be able to receive this information and then store it and make it available for all providers who are using the HIE to get data. So is it exchange? It certainly is information exchange. Okay? It's transferring knowledge from one clinician to another. Is it technical exchange? Well, okay, you parked it in a central place. Yeah, but it is exchange, okay? So last but not least here, there are other uses for something like this. So physician orders for life-sustaining treatment, you know, required in California, pieces of paper. And I myself experienced this with my mother in Texas. She had a living will. It was not available when the EMT showed up. She was intubated. We had to withdraw care afterwards. That was not a fun process, let me tell you. So these things should really be available to all the providers who can possibly see the patient, including emergency personnel, who I find must go through an incredible, painful process when the family's saying, she has a living will, and they're saying, where is it? We don't know. And now what do you do? And now you put them in a terrible position. So I think that's very unfair for them. Care venues outside of the EHR incentive program, nursing homes, chronic care facilities, they really weren't part of ERA. Neither were emergency personnel, so they're not going to have EHRs, and I doubt they're part of the HIE network right now. So maybe this would be a place where they could get some of this data. And then foster children was an interesting one that came up related to foster children records, where they go to multiple different homes. And I'll leave it there. That's the idea. Project Inspire, data capture, data exchange using standards, thinking of registries in a different way, and this idea of the health information home as kind of a regional, geographically focused, patient-centered longitudinal record. Thank you.
Thank you. It's so exciting. We're going to get better care.